Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show.
My name is Dr. Christine Blake Smith. I'm a family practice, addiction, and lifestyle medicine physician and a clinical coach within the Compass Opioid Stewardship Program. This week's case focuses on transitioning a chronic pain patient from long-term methadone therapy to buprenorphine using a slow and patient-centered approach. The goal is to improve patient safety by transitioning a chronic pain patient who had been on methadone for over a decade to buprenorphine while minimizing withdrawal, preserving function, and maintaining trust. This is a 54-year-old woman with chronic pain who transferred to my practice in late 2021 after her prior provider had lost his license. She had been on methadone for over a decade and was already tapered to 50 milligrams per day when we met. She wanted to transition to buprenorphine. As you know, best practice is to taper methadone to about 30 to 40 milligrams per day before attempting the transition. We met at least every 4 weeks. Her progress was slow and appropriately so. She had significant life stressors, a spouse with early onset dementia requiring full-time care, a business for sale, and a young child at home as well. Forced tapers are not appropriate, and patient readiness really matters. Over about 18 months, she gradually tapered from 50 milligrams down to 30 milligrams per day. Throughout this process, she had naloxone available, withdrawal education, and a safety plan in place. Once she was at 30 milligrams, she was anxious about transitioning directly to the buprenorphine due to methadone's long and predictable half-life. After shared decision-making, we transitioned her from methadone to oxycodone first, which is safer and easier to bridge to buprenorphine. She reduced methadone to 10 milligrams and added oxycodone, accepting a significant but intentional MME reduction at that time. Over time, she fully tapered off of the methadone and eventually stabilized on oxycodone alone. In early 2025, she attempted to stop the oxycodone altogether, but she couldn't due to persistent pain. At that point, we initiated buprenorphine as a microtitration using a low-dose patch while tapering the oxycodone. When she developed adhesive reactions to the patch, we transitioned to low-dose buprenorphine/naloxone, carefully documenting the rationale for off-label use due to insurance barriers. She's now stable on approximately 1 milligram per day of buprenorphine. Her pain is controlled. She has no withdrawal symptoms. She's cognitively clearer, and she's really thriving. She's been stable for over 6 months and feels like her life has fundamentally changed. Here are some key clinical pearls. Methadone is not recommended for chronic pain due to unpredictable pharmacokinetics, long and variable half-life, and QTC prolongation risk, as well as drug-drug interactions and overdose risk. Providers must be very experienced, and EKG monitoring is often required. Methadone for opioid use disorder can only be dispensed through certified opioid treatment programs. State laws for methadone prescribing can vary. When transitioning from methadone to buprenorphine, tapering to 30 to 40 milligrams per day improves safety and tolerability. Microtitration can be a far better tolerated option than traditional induction that requires withdrawal, especially in chronic pain patients. Buprenorphine comes in multiple formulations with different FDA indications. Pain-approved products use much lower doses than the opioid use disorder formulations. Off-label use is acceptable when it's clinically justified and it's well documented. Chronic pain dosing is typically divided, unlike once-daily dosing for opioid use disorder. This case highlights that lower than expected buprenorphine doses can be effective. Start low, individualize care, and aim for the lowest effective dose. Slow progress is still success. Consistent support, education, and encouragement really matter, and pharmacy collaboration is very helpful as well, especially when the taper is complex. The Compass Opioid Stewardship Program offers resources for opioid tapering and buprenorphine initiation. Methadone transitions are complex, so reach out to your clinical coach if you need individualized support.
This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's Compass Opioid Stewardship in Practice. Thank you for being part of the Compass Opioid Stewardship Program, and thank you for all you do caring for your patients. See you next time.